We're very pleased again this year to have a special presentation from the Health Information Management System Society, better known as HIMSS. Please join me in welcoming Tom Leary, the Vice President of Government Relations at HIMSS, where he leads the organization's public policy initiatives and outreach to Congress, state legislatures, federal and state agencies. He guides a team that provides legislative and regulatory analysis and practical guidance to health IT policy development. Mr. Leary obtained his bachelor's degree in history and political science from Rutgers University, his master's degree in legislative affairs from the George Washington University. He is a certified association executive, CAE, through the American Society of Association Executives, and has completed the Georgetown University Executive Leadership Certificate Program. Ladies and gentlemen, Tom Leary.
Hi, everybody. I'm also a big Buffalo Bills and New York Yankees fan, and I'm the father of two growing young men who are. One was 2 and one wasn't born when I started on this journey with HIMSS. The oldest one is now driving. He's 6'3", and his younger brother is my height, so is at the age of 13. So health IT has weighed me down. I used to be 6'7", not really, but I've been on a wonderful journey, with HIMSS for many years. I want to share some of it with you today. But first, one of our biggest, I'm a biggest fan of this person, and one of our biggest advocates, in fact, a former Advocate of the Year from the great state of Michigan, is Helen Hill, and today's her birthday. So everybody knows Helen. So. And so we'll spare her me singing, but anyway. So I wanted to take the opportunity to talk to you a little bit about HIMSS for those of you that aren't HIMSS members, but then also just talk a little bit about the landscape, particularly in Washington, on a few things that we're tracking with respect to interoperability and cybersecurity, and of course the opioid epidemic that we're all the states and communities and the federal government are wrestling with. But I also wanted to engage in a little bit of dialogue that I've been having the last few weeks with the Department of Defense as they begin to think about are they really truly going to be able to be interoperable if certain conditions aren't met. So maybe we'll get into that in a few moments. And then the final item that I want to make sure that I empower you with is, as HIMSS, as a global organization, I'm part of HIMSS North America. And HIMSS North America for the longest time has been this country called the United States, when in fact, when you look at the map, HIMSS North America is Canada, the United States, and Mexico, and then then there's some discussion around how to engage with Central and South America. But our board of directors, including Dr. Mike Zarukian, who's the Chief Medical Innovation Officer for Sparrow, just down the street, has challenged us to truly meet the policy needs of the overall organization and start with our neighbors to the north in Canada. So I'd love to engage with you a little bit on that conversation. So just a little snapshot, your eye chart for the day is our government relations team. And basically what you see up there, if you can read that well or see that far, is we have historically been in 3 lanes: federal, congressional, and state. And as of last Tuesday, we welcomed home, air quotes, 2 individuals who used to work with us on the federal and congressional side, Jonathan French and Arnold Simmons, who run our Davies Award program and also run our quality program. So they're with some reorganization of the overall HIMSS entity. Those 2 gentlemen are back with us, if you will. The other individual that I'd like to highlight, just make sure that I wait until she puts something in her food in her mouth, is Miss Alana Lair, who is our Associate Manager of State Government Affairs is here today with me, as well as Mr. Evan Dunn, who's in the crowd as well. He's our coordinator for federal and state government affairs. So making sure that we're well represented to be able to help answer your questions today. But our mission as a government relations team is just to make sure that we put it all in perspective, is to ensure that HIMSS as a thought leader is leveraged as a trusted advisor for governments, whether it's at the local, municipal, state, provincial, or federal levels. And increasingly, as HIMSS, with our new CEO, Hal Wolf, who's a former CIO out of the Kaiser community, and then was with Chartist Group for a few years before coming to HIMSS. He's encouraged us as an organization to make sure that what we're saying from a public policy perspective and the thought leadership that we have provided here in the United States, that it translates to other parts of the world where HIMSS is involved. So our initial foray into that is going to be with our Canada initiative that I'll get a little more into in just a few moments. The second thing is really leveraging those of you that want to be involved in a HIMSS activity as subject matter experts, whether it's privacy and security or ambulatory health information systems or hospital-based or mobile telehealth, interoperability, et cetera. It's really to leverage that voice, the practical voice of our membership as we engage with public policy leaders at all levels of government, as well as to leverage the resources that we as an organization have developed. And we're both known for our Emr Adoption Model that's been in place for about 12 years now. And a little known fact about the Emr Adoption Model is it started out as a 7-stage process. But when the HIMSS analytics team did the first real look at at the data of where hospitals were across the United States, in 2006, a full 30% of the country did not have the basics of laboratory, radiology, and pharmacy in place in order to meet the stage 1. So we had to create a stage 0. So as you've looked at over the course of time, stage 0 has gone from 30% of the hospitals in the United States down to just a little over 2.5%. But even in the years post high tech that you and I we've all celebrated the successes and borne the scars of we still have 2.5% of the nation's hospitals that don't have even the basics for an electronic health record. So from a public policy perspective, it's really leveraging the subject matter expertise of our members and all the folks in the crowd here today and the experiences of organizations like the Stage 7 award winners. Henry Ford is well represented here today, as well as Sparrow. Both are two of the hospitals in Michigan that are Stage 7 winners or recognized organizations. It's leveraging those experiences of those that have gone through the entire journey to help policymakers make it easier or more effective for those that are still on the journey to make their way further along on this digital journey that we're all on. And finally, from a GR perspective, a lot of people don't equate the fact that that government officials need professional development, just like the rest, you and I as health IT professionals. So what we do is, as a GR team, is we look at and we work with folks in the states, like like Dr. Neff's staff, for example, or other folks across the country, and we help them find ways to improve their professional development so that they keep their skills up, but they also make better public policy. So a little bit of a long-winded way around it, but that's really what we're all about from a GR perspective. And then in terms of as we build our public policy, we have really focused on 4 key pillars that we believe will transcend that are borderless here, whether it's the United States or Canada or the folks that I've been talking to lately in Malawi or the World Health Organization that we're starting to talk to. There's really 4 key areas that we're focusing on: is supporting healthcare transformation. You basically drive a truck through that, but if you think about it, it's really leveraging whether it's advancements in cybersecurity or advancements in telehealth or mobile applications, and to really move us into that vision of that Aaron talked about, so that and Adam's, in the panel that was up here earlier, so that we have broad engagement of information technology to deliver better care and really transform the delivery of care in the United States. Secondly is expanding access to high quality care. Again, pretty well described, but it's to me what's happening in Washington and across the states. Really, the conversation around mobile health and it's expanding telehealth and those are the types of things that where we can all work together to make sure that the policies are right, so that so that we can truly make advancements in care delivery. Third item is a bit of a head scratcher for a lot of people until they start to think about it, is increasing the economic opportunity both for the individual and the organization. Let's face it, here in the United States, we've been through the Meaningful Use program. We've seen advancements and we've seen companies start up with new ideas. And as we become a more mature market in that transformation of care, there are countries across the world that are looking to learn from and take advantage of or leverage the improvements that we've brought to information and technology community. So there's an opportunity for companies to look beyond the borders of the United States to begin to sell their wares to other parts of the world. So HIMSS has worked very closely with the United States Department of Commerce to help particularly small and medium-sized companies begin to understand what it takes to engage in other parts of the world. Now, as Adam referenced earlier, the GDPR, the privacy changes that are impacting the EU countries. What does that mean for if I'm a small or medium-sized company that's trying to figure out how to engage particularly in Europe? How do I wrestle with that? Those are the types of things that HIMSS tries to educate policymakers, but also educate our members. And finally, making communities healthier, and that really comes from the idea of leveraging information and technology so that we truly make sure that we don't have haves and have-nots. Several years ago, we started a committee within HIMSS that focused on underserved communities, and it's now the NHIT Collaborative for the Underserved, and we work very closely with the Association of Clinicians for the Underserved, making sure that as we move on this 21st century journey of IT, that we don't forget about certain communities. And 2 years ago this week, as part of this conference, we began a conversation with MyHIN and with the Michigan chapter of HIMSS and with the Office of the National Coordinator, and Karen DeSalvo was dual-hatted at the time. She was also the Assistant Secretary for Health. But we started on a journey to really figure out how health IT could be leveraged to help communities, whether in crisis or public health crises, whether it's a human-made instance, as might be described, the water crisis that here in Michigan, and the reason why we started the conversation, or if it's natural disasters, that, whether it's tornadoes or earthquakes or hurricanes. The idea has been to help communities have a checklist or have a way forward so that they're prepared for crisis, or as they're in crisis, they can begin to mitigate the challenges. And later this month, we're actually working with the NHIT Collaborative for the Underserved on some of the lessons learned from Puerto Rico and the Virgin Islands, where as much as 30% of the community still doesn't have power nearly a year later. So how do you provide the best quality of care for that? So that's really the four pillars that we're at. From a policy perspective, I can't do it enough justice the importance of our community's help to really deliver on the challenges and the problems of health, the opioid epidemic. Whether it's in the state houses, where I understand that here in Michigan, or a good number of pieces of legislation went into effect last Thursday on June 1st, or that might have been Friday, but to more that are being passed that are being implemented on July 1st. It's happening across the country, but just as importantly, it's happening it's at the national level, where the House and Senate are trying to think through how do we solve more than one problem with one piece of legislation. So what they've been doing is, what we're seeing advance through the House and now making some traction in the Senate, is telehealth legislation that also includes language on e-prior authorization, speeding up the process by which information gets shared, and providers can then react in more timely manner, to also the e-prescribing of controlled substances, making refinements to the process that's, sadly enough, we've had an interim final rule on e-prescribing of controlled substances in place through the Department of Health and Human Services and the Drug Enforcement Agency since 2008, and so a full 10 years later, Congress is saying enough with this interim final rule that everybody's been operating under. Let's really move forward on advancing and utilizing technology in a way that we can get a better handle on what's being prescribed and who's prescribing what's being prescribed, and who are the individuals that may need help as a result of their seeking a prescription from multiple sources. In addition, telehealth legislation is really moving again. The Kinect for Health Act, several provisions were included that, for those of you that are concerned about telehealth or hopeful that it's like me, that it can really help us with the healthcare transformation. The Kinect for Health Act is hopefully going to be the crowning jewel for Senator Orrin Hatch from Utah as he gets ready to retire. But the idea is that finally CMS, from a Medicare perspective, will begin to reimburse, at least on a limited basis, of some telehealth provisions. A lot of people scratch their head about that, and they say, well, Medicaid's been doing it for years in several different states, or the private insurers are doing it on an individual basis, through whether it's Blue Cross Blue Shield or Aetna or United Healthcare Group. But from a CMS perspective, it's always been very narrowly defined, and it's been defined by the type of technology that you use and the location that you provide the care in. So for the first time in 22 years, there's enough of a change in the legislation to allow us to explore whether or not Medicare should really get into the telehealth game. In addition, just from a HIMSS perspective, for those of you that are HIMSS members, we're really focusing on, the appropriations process. We're hopeful that for the first time in nearly 15 years that we'll actually have a full appropriations process for fiscal year 19, but paying very close attention to the healthcare provisions that were put in place as part of the omnibus in January, but then also, you've read the headlines, I'm sure, that there's a rescission package that Congress has been presented by the Trump administration with the idea of pulling back on some of the, particularly the healthcare provisions that were passed and signed into law back in January. From a federal and state themes that we're really focusing on, we've spent the last couple of days talking about TEFCA. Other items that that we're really tracking are, if you had the pleasure to be with us in Las Vegas earlier this year when CMS announced their My Healthy Data initiative, the idea of Blue Button 2.0 is one of the key components that we're tracking, that you heard about earlier this morning. But it all ties into this administration's, the Trump administration's belief that there's too much provider burden, and that the idea of reimagining meaningful use to a point where we can now, 9 years later, we can make adjustments to the program and really move forward on refining the types of e-clinical quality measures that will be used, as well as how do we get providers back to more of a face-to-face interaction with patients as they've been complaining about or making observations about for the last couple of years. Information blocking is from an interoperability community perspective, there's provision in the 21st Century Cures Act that requires the Office of the National Coordinator to define what information blocking is not. So, and if you're in violation of what they eventually define as if you do something that's not on the list of what's not information blocking, it can be $1 million fine per instance. So the healthcare community, and I'm sure all of you are paying some attention to it, is waiting on this definition of information blocking. And what we've been really engaged in is a dialogue around who defines what information blocking is out in the community. Is it someone who had some form of registry, a medical society that's had a registry that has enjoyed gathering information from their providers directly, and then they are able to utilize that data for various services, and all of a sudden now that the providers have electronic health records, there's a big concern that the EHRs aren't talking with the registries well enough, so therefore it's the EHR companies that are creating an information blocking scenario. Or is it a provider, a large health system that won't share their information with smaller practices in the community unless they join the bigger organization? That's all going to play out over the next year, and with that $1 million price tag per instance, a lot of folks are trying to make sure that they're not what their business practices are don't get included in what is information blocking. And as far as the DoD and the VA be moving towards the Cerner product, and now Coast Guard is signed on with DoD to tie in their EHR efforts and on the piggybacking on DoD, so that they're going to leverage the MHS Genesis. It's really what it comes down to is the concerns of cybersecurity. And Pat Flanders is the new CIO for the Defense Health Agency, and I was sitting with him at a meeting recently, and he said, "What is the #1 challenge, do you think, to interoperability?" And I, of course, started talking about trusted exchange and making sure that we have the governance in place and who's uses it's the correct interpretation or the common interpretation of standards. He stopped me and he said, "No. The biggest challenge for the Department of Defense is our cyber footprint, our cyber requirements. We have 50% of our patients, active duty family members, and retirees. go and seek care outside the four walls of a military treatment facility. And we are required to figure out a way to get information back from those downtown providers. Many of you may, see active duty or retirees, and you may be experiencing some of these struggles of trying to get information from the military's EHR or putting information back in. He said that the challenge for the Defense Department is that we're a cyber-aware organization. We have millions of hits from all across the world trying to get into us, and from bad actors on a daily basis. So as the the CIO for all of the Defense Department increases the requirements for the Defense Department, it's also requiring us to increase the requirements for our downtown providers or our, the TRICARE providers, et cetera. So that at some point, he believes, and he's hearing from a lot of people, that we're going to reach a point where the community's going to cry uncle. We can't afford to keep pace with the Department of Defense. We can't afford to even think in the way that you are thinking as a DOD. So what he's hoping for, and I'm hoping for as part of our dialogue today, is anyone actually, are you experiencing that kind of thing, or would you agree with him that the Department of Defense is hyper paranoid about cyber, particularly in the healthcare space? So maybe we can catch up throughout the day about that, or if anybody, I see somebody giving me a thumbs up. The idea then translates. You look at that bullet point, the Department of Veterans Affairs. They're a partner. They serve veterans. Veterans at one point are active duty or active duty family members, et cetera. So in order for VA to interact and share with DOD, they have to meet the DOD requirements, and they therefore will require their partners to meet the cybersecurity requirements. So that's, I know, maybe beating a little bit of a dead horse here, but that's one thing that we see that's out there that's people really aren't addressing with respect to, we're all concerned about cyber, but at what point does the guy that's most Fort Knox about his data, his or her data, at what point does he reach a level that nobody else can achieve? So watch for that in the next, over the course of the next few months. In addition, just with respect to, I want to make sure that we, as we talked about interoperability, understand that the VA and the DoD are really interested from a healthcare perspective. As healthcare providers, they're interested in engaging with all of us. I know that several of the organizations that are on the panels throughout the week, whether it's Commonwealth or Sequoia or even, I'm sure that MyHIN has a level of engagement with both VA and DoD. They're willing partners. They want to make sure that they do right by the veteran, they do right by the active duty or the retiree, and they're actively interested in engaging with all of you. So as we look for the rest of the summer and into the new year, or the fall and then into the new year, the one big thing, I guess, across all government that I see that want to make sure that in terms of engaging the patient, a lowest hanging fruit when I talk to folks in Washington or folks in communities here or some of the folks that I interacted with at the Global Health Forum back in December and earlier this year at some other conversations is immunization. Irrespective of where you are in the world, it seems that IT professionals and clinicians who are worried about or interested in secure data sharing, they're absolutely see as one of the lowest hanging fruits is immunization. Who's been vaccinated, who hasn't been vaccinated, and where the stockpiles are, so that we can get the information, we can get the right doses to the right part of the community. So one of the activities that HIMSS has underway that I hope we can, we were talking to the MyHIN folks earlier today about potentially seeing if there's a collaboration opportunity, is the CDC has developed a series of tools for EHR companies to test, to make sure, test their EHRs against these CDC tools so that to make the connection between the EHR at the doctor's office or the provider's office and the immunization registry, whether it's at the county level or at the state level or even at the or even reporting into the CDC, to make that bridge smoother. So what I encourage you all to take a look at is on the HIMSS website, and maybe we can talk in the hallway, is if you're, whether you're a company or you're a provider organization, if you feel that, that it's high time that we get the right information about who's been vaccinated, who needs to be vaccinated, and where the stockpiles are, that we come up with a standard approach, a common approach across communities to answer those three questions. I'd love to engage with you on how we can share with you the work that we're doing with CDC, but also the work that's I understand is happening in other parts of the community. Finally, our neighbors to the north. They've, just like us here in the U.S., they've got big concerns about the opioid epidemic. They've got big concerns about data integrity. They've got big concerns about the data that data that actually gets shared across the community. But just as importantly, between providers that either patients from Canada that are seeking care in the border states, or patients from the United States that might seek care over in Canada. So as HIMSS launches on our Canadian initiative, we've been talking to the Cross-Border Health Foundation about how do we, what is the lowest of hanging fruit that we can work together on to begin to address some of the regulatory challenges and the data sharing challenges on each side of the border. And it's, and believe it or not, we're not starting with immunization, we're starting with opioids. And we're hoping for, the Cross-Border Health Foundation is hoping to have a conversation, a U.S.-Canadian conversation at the University of Windsor, just on the other side of, across the river from Detroit, later this fall. So that's one area where I hope that the Michigan community can help me help them so that they can help educate their version of the FDA and CDC and their version of HHS, really make the regulatory changes so that data flow across the border can be improved. But also, as we, HIMSS as an organization, global organization that's, we run real hard on a policy perspective in the United States, but we're beginning to walk and hopefully getting to a jog across the world, and how we can leverage U.S. lessons learned in public policy in Canada, that we can partner between the HIMSS government relations team and the communities in Michigan to make sure that we don't have unintended consequences that adversely impact your ability to provide care to Canadians who might come across the border, or have trying to get information on patients who might have, Michiganders who might have gone across the border and then come back. So, I guess as part of the luncheon discussion, really, I mean, those are the things that I see as we move into the summer months: opioids, immunizations, and the impact of cyber, as three key areas that we'll be working on. And not to mention, there's many others, infrastructure, et cetera. But I enjoy working with the communities in Michigan, and I look forward to working with all of you, and hopefully we can gather some of your ideas to make sure that we have scalable public policy as we engage with, at the state, federal, provincial, and local communities. So again, thank you for the opportunity to chat today and give you a little of my insight, and look forward to the rest of the conference. Thank you.